I just spent 5 minutes of finding the appropriate angle and performing inferior glide to that ilium. So I'm going to redo that spring test, or force transmission spring test. So I take up the slack, and I like to pause a little while. Do you see the recoil is returned? That's not me. Okay, that's your body. So that's good to see. I don't see this as looking as prominent. Okay, line your stomach. And some will argue that there's not good intertester reliability, but there actually is good intertester reliability on my approach of palpation and even of this passive movement testing, and that's from a thesis on my work. It's a master's thesis done by Luann Olson, who was at Finch University in Chicago. And so now you're prone. So I'm scooping under the ischial tuberosity. I put my heel there and capture it, and I take up the slack, and you can see the whole body moves with that. So the slack is being taken up in multiple areas, not just the SI. If I had the strength of a gorilla, then maybe I could stabilize the sacrum and spring on the ilium only, or put a nice big bolt in there and tie that to a ratchet, and you get the drill, right? So it's not possible for me to take up the slack only in that joint, but I take up the slack through everything that readily moves when I impart 15 pounds of force. Anyway, I'll be quiet now. So we take up the slack there, which we couldn't do before. I spring it, bounces right back. Okay? So I'm going to do the inferior force transmission test. So there's the iliac shelf again. Take up the slack, spring, spring, spring. Okay? And I'm going to point the camera. When I do this test, I look at the feet, because I want that force transmission to go through the pelvic structure. Notice I'm not saying joint, I said pelvic structure. And I want it to traverse down the lower extremity. Okay? So you'll be able to see when I've taken up the slack in the structure, and that's now. And I'm going to spring it, 1, 2, 3. And you see it just bounces right back. It has elasticity like a shock absorber. So we do have improved force transmission through that joint. And earlier it felt like it was unstable in rotation. And I feel like now that's just not the case. I can now create rotation when you're on your back, and it bounces right back with the same integrity as the other side. So we call this a positional laxity that corrects with repositioning. Now, there are also neurological models that can explain it in other ways, but what we do know is in a high probability something changed here. Could you test that? What would be the best way for you to test and see if you perceive something different? And I'm going to keep filming.
Okay, so with extension, I had pain earlier because I know I've done this a couple times today, tried to kind of extend my back and stretch out, sort of speaking, but I had pain in that SI area,
okay,
and it felt like something was jammed in there, like
okay,
I previously said on a couple occasions, and now it's not there.
So you can bend backwards now.
Well, I have decreased lumbar extension because of my decreased decreased lordosis, but it's in that SI area, it's not as stiff as painful as it was.
Okay. So right now you can bend backwards, whereas this morning it was painful.
Right.
Would walking tell us anything?
Probably.
Okay, so go ahead and take a...
Okay,
Your thoughts?
So also not as painful.
Not as painful
Not as
walking.
painful
Good.
walking, and there's more rotation in my hips.
Nice, nice. Good. It all sounds positive, and I'm going to encourage you to wear that belt because there are people who have a subclinical laxity. I had a woman, and I couldn't make any assumptions about laxity because the spring testing felt very appropriate, and she did several weeks of rehab, and I thought she was doing well. Her effort was great. You know, she put forth very good effort, and then she cried the day I asked to give her a letter. She said, "Will I ever get better?" I said, "What do you mean?" She says, "I can't play with my kids." This, you know, and she went on, and I was bewildered. So I said, "I better look at everything again," and I did, and I came up with nothing that I could explain, and I just put an SI belt on her, and it was immediate. You could see it in her face. And long-term follow-up, communication with a physician, she did great. So there are people that have a degree of laxity or hypermobility you can't discern. And so in your case, given that it historically helped you, I'm still on that thing of using it for 6 weeks. And because you'll be more active with it and have less pain, you actually will get stronger using it. People have a belief that wearing a support makes them weaker, but if it lessens pain and makes the person more active, then I see it as a positive thing. And the goal is to wean it. And if you inhibit any muscles, then when you wean it, you'll strengthen them right back. So I'll stop right here. But in summary, we found someone who had hypermobility in posterior rotation, had no mobility in superior or inferior glide force transmission, and we treated it for what I call a type 2 downslip. I named that pattern in 1985. There's actually 3 kinds of upslip and end of downslip, but the literature tells us about one only. So when treating that for 5 minutes in the ideal angle, this is the response that we achieved. So I will stop right here.